Go ahead, ma'am.
Hi, I'm Dr. I'm not able to see the slides. Yeah, thank you. Hi, I'm Dr. Jahnavi. You can see me at Oasis Fertility Center, Tirupati. Now, today our topic is about poor egg count and quality, and what are the methods, both scientific way and pharmacological way, which we can do, and what are the management options that you can do at home to increase the egg count and quality. So, and these are my credentials. So let's go to today's topics. We are going to see what is poor egg count. We call it poor ovarian reserve or borderline ovarian reserve or low egg count. What are the criteria as to how do we define it? Is there any set criteria to say that this woman has poor egg count? And what are the reasons behind poor egg count? What could be the probable reasons? Because it's on a raise now, and what all interventions we can do as doctors. A little bit in summary I can tell you, and what are the treatment strategies we do for those patients, and what are the modifiable factors what we can do from our side to change that, and upcoming advances, what are the recent advances, those also we are going to cover today. Next thing is what is called low egg count or poor ovarian reserve, or the other spectrum is poor ovarian response is also there. So when a person develops insufficient number of follicles after giving injections, that is called gonadotropin stimulation, then it is called poor ovarian reserve. So what decides that? The egg count which is present in our body is basically determined with the age, and it is basically stagnant from the time we are born. It is decided by the time we are in the mother's womb. So we are born with a specific number of eggs, and it gradually decreases with age. So this is how it goes. You can see that plain line which is there, that determines the gives the egg count. You can see as the age progresses, the egg count slowly decreases. The other most important thing is as the age progresses, the egg quality also slowly falls down. So the number of poor quality eggs, this dotted line here represents the number of poor quality eggs, which is going to go up as the age increases. You can see in the pictorial representation, this is how a young ovary looks like. When I see a scan of a woman around 20s, then I will usually get this picture where there are lots of eggs which are there in the ovary. But when they gradually progress to 30s and 40s, that is how the number of eggs will go down. And what is the how many women do have this condition of poor ovarian reserve and response? Around 99 to 24% is the incidence, and it has been gradually increasing. 61% of the IVF clinics have reported an increased incidence in poor ovarian reserve. In the last 10 years, there has been a rapid increase in both PCOS on one end, where the female has lots of eggs, but none of them are having proper quality. And in the opposite spectrum is the poor ovarian reserve, where the woman is having very less number of eggs to begin with, and this is very difficult to treat. So here is again one more estimation as to how many eggs a woman needs to conceive. See, this again depicts the egg quality in return. This is a surrogate marker for egg quality. That is how this has been given. You can see when the age is less than 35, even six eggs will be able, 6 to 8 eggs we can tell, will be able to give us a good quality embryo and a pregnancy. But as the age increases, because of the decrease in the quality of the egg, the reasons for decreasing the quality of egg are mainly genetic, and as the aging progresses, there are some changes inside the cells, inside the eggs of the female. So that as the age increases, we need more and more eggs to achieve that one good quality embryo, which gives us a pregnancy. So, as early as possible, if you are planning a pregnancy, as early as possible, if you do, you will have a more chance of success rate. And here the ages which have been studied are less than 35 years, 39 to 40, and 42 to 43. And how do we define them? So when compared to women of similar age, if a woman has less eggs, then it is called decreased ovarian reserve. What is decreased ovarian response? when we see in scan that the eggs are normal in number, and her blood test also shows the same, that the eggs are normal in number, but when we give her the injections or when we give her the medicines, but she is not getting enough response, that is, out of 10 of her eggs, only 2 or 3 of them have grown and rest of them have not responded, then it is called decreased ovarian response. So we define these two differently because the management varies a little bit in between these two. So to come into proper definition, this is an older criteria, Bologna criteria. Both these, whatever I'm going to tell, two criteria, those are scientifically used and have been studied and proven very well that there is advantage in classifying women as these in these criteria. In Bologna consensus, what we do is, if a woman has any two of the three following criteria, we categorize her as poor ovarian reserve or poor ovarian response. If the woman has age more than 40 years, and if she has already underwent an IVF or a stimulation and it has resulted in less than 3 eggs, if the woman has any of these tests as positive, that is, if her egg count is less than 5 or if her AMH is less than 1, then we can call her. If any of these two are present in a woman, then we call her poor ovarian response. Then let us see another criteria. This is again a little more sophisticated. Here, what they have done is they have grouped women into 4 groups, and young females with less than 35 years age who have in them uh, less number of eggs in them are a little different with older females who have less number of eggs in them. That's why they have made these criteria. You can see these are in group 1 women, these are young females, that is less than 35, with good number of eggs. But when we give them the injections or when we give them the stimulation or medicines, they're not responding the way they have to usually respond. So these are grouped as group 1. Group 2 is patients who are more than 35 years of age, but they have good number of eggs. And obviously, when we have given them the injections, we have not gotten good number of eggs. Those are group 2. Now, group 3 is young women who have less number of eggs to begin with. And group 4 is little older women who have less number of eggs to begin with. So this is how these groups are categorized. Now, what are the possible, probable reasons for poor ovarian reserve? Elderly patients, like age group more than 35, more than 40, and most of the causes are unidentified as well. Patients with high FSH, low AMH, and AFC, and small ovaries. Ovarian surgery, like endometriosis surgery, or surgery for ovarian cyst, or surgery for polycystic ovaries, where there is laparoscopic ovarian drilling done, that also can reduce the response. So it is very essential that when a surgery is being done on the ovary, it is done with utmost caution, especially in young female. Then there are some genetic defects and autoimmune diseases which can cause low ovarian reserve. And women with single ovary and the other ovary removed because of other surgeries like torsion of ovaries or a cancer of ovary, anything like that sort, can cause decrease in ovarian reserve. Any chemotherapy or radiotherapy because of carcinomas of other organs also, if it is affecting that, if the radiotherapy is given in the areas where ovary is there, that can also affect the ovarian reserve. So chronic smoking and other risk factors are diabetes type 2, and other procedures which can cause problems are uterine artery embolization, which is done for fibroids. Reasons for poor response. In this, we are talking about women who have good number of eggs, but they are not yielding so much when we are trying for an IVF. These patients are usually elder patients, and they will usually have a history of poor response also. And genetic defects, autoimmune defects can cause this. Chronic smoking also can cause this problem. And hormonal imbalance, like if the thyroid is not corrected or if prolactin is not corrected, then also they cannot give optimum response, and unidentified causes are also there. What happens if a woman has poor ovarian response? That is, she has not yielded what we have expected her to give. So then we try to change the protocol. There are several other protocols which are there. I'm going to name them later on. And we will plan for a repeat IVF stimulation. This can get a little expensive, so it is a challenge in lower socioeconomic group, but it is the way to go. We plan for a repeat stimulation with a different protocol, which might give better results for her. We try to increase the dose of injections because we have various types of new injections also in market, and we try to change the dose of injections and alter the composition of the injections also. Then we add adjuvant medicines also, like some hormones which are there, some steroids which are there, we can add. I'll come to that again. And there are some lifestyle modifications which definitely we advise women with poor egg count to start before going to IVF itself. Then always there is a donor oocyte program. Then options for women with poor ovarian reserve. The woman has less egg count to begin with. What we can offer them is we offer them repeat stimulation. We offer them something called embryo accumulation. That is, like I said, as the ovarian reserve decreases, the egg quality also decreases. So it makes sense to collect as many embryos because we need more number of embryos to get one good quality embryo, more number of eggs for that matter to get one good quality embryo. So in that case, we offer women to do 2-3 cycles simultaneously. I mean, 2-3 cycles back to back, so that we can collect as many eggs as possible to get that very one good quality embryo which can give us a pregnancy. That is called embryo accumulation. Next, we try to increase or we try to alter the dosage of injections. We try adding adjuvant medicines for that to improve the egg quality. We request her to alter her lifestyle, like stopping smoking and eating healthy food. We'll come to that again. And if this is all not working, there is always a donor oocyte program. So, what if the conventional protocol fails? This is what we have spoken about. If we do a rotating stimulation and it fails, then we have something called mild IVF or modified natural IVF. This is a little bit pocket friendly IVF where we are going to give very less dose of injection, so it costs the patient less. If a woman is giving just 2 eggs, if I give lots of injections, we'll be able to collect 1 or 2 eggs with very less dose of injections also. It makes sense to give very less dose of injections, collect that 1 or 2 eggs, and go for a repeat stimulation. In that way, we can do 2 stimulations at the cost of 1 cycle. Then modified natural cycle is most of these women will be having natural egg growth as well. So we need to monitor that egg and collect that egg. That also can be done, and almost most of the drugs are cut off in that, so that it comes at a very affordable price for the patient, and the patient can go for repeated cycles like 3 to 4 cycles. The natural IVF, the only one disadvantage is you might ask me why we don't go for natural IVF for every patient, for the patient with normal response also. Because this is the one disadvantage. It is, first of all, very stringent monitoring is needed in natural cycles because it is not manipulated. We do not have that much control over the cycle. And so it has high cancellation rates. That is, the eggs tend to mature very fast, or eggs tend to released before they reach the full maturation. So that can happen in natural cycle patients. Then there is something called double protocol where time is of the essence. Then, like in patients who are going for chemotherapy, or who are having ovarian malignancy and they are going to be operated. For them the time is of the essence. So what we do is we try to get as many eggs as possible in shortest span of time. That is, repeat stimulation in just 1 month cycle. We can do 2 stimulations and collect as many eggs as possible. So that is called double protocol. Next, can we increase the dose? Repeated very high dose of giving gonadotropin injections. I have seen people giving pumping people with lots and lots of injections, more than 450, 500 also dose has been given. And there is no proof that giving very high dose of injections is going to increase the response. 300, 375 and 450 per day has shown us to be having good response. Then oocyte and embryo accumulation. Yes, embryo accumulation we have already discussed. We can collect eggs, make embryos and freeze for successive cycles without a gap, so that after that we can have good number of embryos even though the age is going to increase, because we have frozen the embryos. We can use those embryos to get pregnancy later on. And recent trend of career orientation, academic orientation of women has also led to this trend of oocyte freezing. If the ovarian reserve is less, and the woman is not willing or not planning for pregnancy or not married also for that matter, if they want to still conserve the fertility, they can go for a stimulation and freeze the oocytes. If they're sure of the partner, if they're married and they want to preserve fertility, then they can freeze the embryos also. This way, they can finish off their academic work and then academic or career work and then plan for pregnancy at a suitable time later on. So, what are the medicines which we can give? This is very important because most of the women who are going with poor ovarian reserve, they do stimulation and they are very eager to start stimulation. But let me tell you, pre-treatment or giving adjuvant treatment is also quite an important aspect, which some of the patients do miss this during the stimulation because they are eager to start treatment. They are worried that their ovarian reserve is going to go down even with 1 month. Yes, but giving this pre-treatment is definitely going to improve the quality of the eggs. Though we are going to get one or two eggs, if we get good quality embryos out of those, then it makes sense to take that pre-treatment and then start the stimulation. So, what are all the medicines which are available? Growth hormone. Growth hormone. The first one is growth hormone. We give it along with the daily gonadotropin injection. Sometimes at least a week before gonadotropin injections, we start that, and then we give around based on the weight of the woman, we can give around 6 to 8 units per day. But it is a little bit costly, but gives us the response, gives us a good quality oocytes or good response in the cycle, so that the number of cycles the woman has to go is going to finally decrease. So that is one thing, and it is given in the form of injections daily. Pyridostigmine, and then we give pre-treatment with estrogen so that we get equal sized follicle, equal sized eggs when we start the cycle, so that the number of eggs can be more. And then OC pills, previously we were doing that. Now we have reduced the usage of OC pills, but still OC pills also can be given for about 14 days or 15 days before treatment so that we can get a synchronized follicles. DHEA, definitely. These are basically androgens, male hormones, but they do have a role in female body also. All females will have small amount of androgens in our body, which is definitely going to increase the quality of the eggs. So, giving this DHEA and transdermal testosterone, I think if a woman has PCOS, if a woman has poor ovarian reserve, we can take that 1 month or 1 to 3 months is what is given. So 1 to 3 months time to give this pre-treatment, especially androgens, to increase the quality of the oocytes we can get. Second thing is L-argin. This is again given in the form of a sachet. It is a little bit expensive, but it does increase the egg quality. Ultra CoQ and mTOR and leucine. These are again adjuvant medicines which can increase the egg quality. These are basically some of the antioxidants and which acts in the mitochondrium and which acts in the egg cytoplasm, which increases the egg quality, the capacity of egg to give a good quality embryo. So if whoever is having less ovarian reserve and are planning to start IVF, better we give 1 month of this pre-medication and give some growth hormone also additionally. Along with that, one more thing that is not mentioned is a little dose of steroids, which we add in terms of Visolone or dexamethasone. We can add; those are the drug names. That medicine gives us again a better response and better quality of oocytes. Then, what are the upcoming advances which we can give? There are there is a vast research going on in this because it's a growing problem, and women with poor ovarian reserve, unlike PCOS, have very limited choices. So, ovarian fragmentation and in vitro activation. There is technology where we take out chunks of ovary and then try to activate the follicles which are destined for death. So we can activate that and we can use those eggs, but it is still under experimental stage. And this ovarian PRP application is again very widely used. PRP is nothing but some cells in our blood will have the capacity to regenerate and grow, or they have capacity to stimulate growth also. So what we do is we do collect blood from the patient, and then we try to process the blood and collect the blood cells which are rich in these growth factors. They help in growth of cells. So what we do, we take out these factors and we try to inject into the ovaries. Once we inject into the ovaries, this is going to stimulate response from the ovaries and increase probably the quality of egg, count of egg, and definitely the quality of egg is a little better. So this is done, and once a session of PRP is done, for the next 2 to 3 months, you can see a better response from the patient. Then there is something called mitochondrial activator factors, which can be applied to the egg. And the other options, this is again ovarian rejuvenation, which we have already discussed. Then other experimental therapies are stem cell concentrate injections and exosome injections. There are few other options also which are available, which is again obviously a donor oocyte program. And the other thing is only the main concern in donor oocyte program is the genetic material of the mother is not there in the baby. So that is what most women are worried about. So research has been going to alter this to address this concern. So if a woman has poor egg, we can there are researches going on where the genetic material only from the egg of the woman is retrieved, and it is transported into the genetic material. It is transported into the egg of a healthy woman. The genetic material of the healthy woman is taken out. So we now have a reconstituted egg where the entire egg is of a young woman. Only the genetic material is from the mother who is going to give birth to the child. Now we have a new egg which is again injected with the sperm of the husband, and an embryo is obtained. So in this way, the concern that the genetic material of the mother is not being inherited by the offspring is eliminated. So that is also being done. The other experimental therapies like a platelet rich plasma, PRP injections, we do have a lot of research going on in stem cell concentrate injections also. Here again, stem cells are collected either from your bone marrow, or if you have cord blood stem cells, or from your blood. Anything can be done. The blood or the products which are obtained are processed, and the stem cells which help in growth and rejuvenation are selected and injected into the ovary. Again, further one step advanced to that is again exosome injections, where these among these stem cells itself, we are going to identify activating factors, most exosomes, which are actual regions which promote growth, and then directly inject these things into the ovary. All these are still experimental stages, but fastly growing areas these are. So soon we might be seeing more and more procedures like this. Then this is again one of the most important and most often asked question in the clinic, where the patient, when I give a diagnosis of poor ovarian reserve, they're going to ask me as to how we can improve, what we can do from our side, because whatever we have given you is going to help to some extent. What we can do from our side to improve the egg quality and egg number. So egg number usually doesn't improve from home remedies, but egg quality to a certain extent can be taken care of. First thing is dietary requirement. Animal source of protein plant source of protein has been found to be superior to animal source of protein to increase the egg quality. So to shift to plant source of proteins is first thing. So pulses and legumes are rich source of proteins. And then exercise is also going to help in regulation of your hormones, and sedentary lifestyle has definitely side effects, so that can be reduced. Diet regulations, antioxidant rich diets. Antioxidant foods are berries and green leafy vegetables, fresh fruits and vegetables. All these are rich in antioxidants, and most of the pharmacological medicines we give are also rich in antioxidants. So that is definitely going to improve the egg quality. Then maintaining appropriate weight for height. Again, obesity also has its own side effects, so that is also going to impact the egg quality and the chance of pregnancy as a whole. So maintaining appropriate weight for height and working on your weight, shedding that couple of pounds or gaining a couple of pounds in few cases is going to help you achieve that pregnancy. Sleep hygiene. Again, sleep hygiene is one of the most important and one of the most neglected part, I should say. Often these couple are so anxious and worried that they do a lot of exercise, and they're very anxious when they go to sleep, checking a lot of videos and all that. So they'll not be able to maintain that proper sleep hygiene of 6 to 8 hours sleep per day. So that is also very important. And people doing night shifts also, uh, uh, this can cause fluctuations in your hormone levels, especially hormones like prolactin, which again is not good for the health. Stress reduction. Stress reduction techniques like yoga and meditation can be practiced, and generally, working on your job and career is going to cause a lot of stress. And there are ways in which we can reduce the stress, so that can be trying. And again, the avoidable factor which we have to address here is smoking, alcohol, fast foods, and caffeine. Caffeine up to 100 mg per day is just fine. So 1 or 2 cups of coffee is fine, but beyond that, it also has some side effects. So decreasing the dose, decreasing the amount of caffeine, either in terms of coffee or tea, has to be reduced. Smoking, alcohol has to be stopped, and fast foods also, it has to be cut down to increase the growth of, increase the quality of the eggs, and also the to preserve the number of eggs, whatever number of eggs are remaining in the woman. So I think that's it. If there are any questions, we can take it. And this is again one of the most growing concerns. So this is again one of the most growing concerns, because when we give the diagnosis that a woman has poor ovarian reserve, they are often at loss. And most people, what we are seeing, are usually they do not have the financial means to go for 3 or 4 cycles of IVF, so they'll not be able to afford for repeated stimulations. So it makes sense to increase, to get good quality eggs fast in those women. Does PCOS has poor egg quality? Yes, PCOS, to simply answer the question, yes, PCOS, women usually have more male hormones than is expected in the body. So the microenvironment in which the egg grows is dominated by male hormones. That is why we have a poor egg quality in PCOS. But with diet, exercise, and with proper medication, obviously, egg quality uh, can be altered a little bit in the PCOS woman over a period of time. Yes. Can you do IVF with a low egg count? Yes, definitely yes. It depends on how low the egg count is. If the AFC is around two, or if the AFC is just one or less than one, that we are not able to see any egg, it may not be possible to do an IVF. But usually, what we see is AFC, that is the antral follicular count, the number of eggs we see in a cycle. If the AFC is around 3 to 4, we can definitely do an IVF. The number of cycles again depends on how many eggs she has and what is the quality of the eggs we obtained, what is the age of the woman, and all that. Okay, does and what should we do and what shouldn't we do after embryo transfer? Hi, Mrs. Santoshi. Sure, I'll answer this question. What should we do after embryo transfer and what shouldn't we do? First question is, what should we do? We should do we should avoid, first of all, heavy physical exercise. And what we should do is be compliant with your medications, because most of the embryo transfers nowadays are frozen embryo transfers, where we are preparing the endometrium with some medicine, so that medicine compliance should be there. Second thing is, you can do your routine physical work. There is no need for bed rest. That is a myth again. There is no need for absolute bed rest. You can do your routine physical work and all your work daily. What we have to avoid is, we usually ask the patients to avoid lifting of heavy weights and something that has pressure on your tummy. We ask you to avoid certain types of exercises like crunches and certain yoga positions. But if you walking is very safe to do. Swimming is again not highly advisable, swimming and cycling, but the other exercises like walking, and if you are routinely doing a little bit of jogging, that is also all right. So, and cooking also, most of the women do ask me this question: can we cook? Can we chop vegetables, or do we have to rest? There is no reason to take absolute bed rest until you have some complication. Until that, you can do your routine physical work. Don't lift heavy weights. Do not, what do you say, do not do crunches and heavy physical work, but your routine work, you're absolutely free to do so. So here is the Oasis Fertility Helpline. If you have any queries, please contact this number. We'll be happy to help. Thank you.